So I'm glad that too you stressed the shared decision-making, because this is complicated therapy. And just like, which I think the American Academy of Neurology wisely recommended in their treatment guidelines, 2 visits, one for diagnosing and then a second visit to go over therapy, because it's a long discussion. It's a very long discussion. And I think that a lot of the individuals come in, they're pretty well informed and bright, with a lot of preconceived notions. And so, for example, we've had a lot of people come in, and when I start the therapy discussion, they'll say, how long has that drug been around? Which means that they're more concerned about safety than they are efficacy. And it skews the discussion. And so we have people who we start on less aggressive therapies because they want something that's been around for a long time and safe. Now, having the grayest hair here, I can tell you that I have people who've done perfect on our earliest therapies. People started in the early 90s on interferon and have had nothing happen to them all along. So we know that there's people who do well on every one of the therapies. What troubles me is that I can't adequately apply the prognostic factors that Tom listed on an individual basis. On a group basis, it's pretty clear, but I don't know about it for the individual. And then the other part of that is, how do we define failure or inadequate response? And we don't have good definitions for that. And the comparative efficacy data that we have, the good comparative efficacy data, is none of the information you're interested in. Right? You don't care if the latest drug that comes out is better than one of the interferons. That's not part of your decision-making process. Right? You want to know how this highly effective drug compares to this highly effective drug, because they may have different safety profiles. And I think we're trying a variety of ways to get at that information, none of them particularly satisfying, I think.
If I may, there is another picture to all of this, and it goes back to what Clyde said when he said, I'm becoming a little bit more concerned early on in patients with my interventions. And that's another concept, is the fact that in our practices we see the patients that have been doing well over long periods of time. We no longer see the patients that have not been doing well because they are in nursing homes or they are no longer following up with neurologists. So the disease severity, the actual severity of MS, is sometimes underappreciated because patients with more advanced multiple sclerosis deafferent from a neurologist and are no longer seen in these practices.
And I think another point along these lines is what is our target of treatment? I would make the argument that our goal really should be to preserve the normal aging process, to keep people as close to the normal aging process as possible if we're really doing our jobs, not to prevent people from hitting an EDSS of 3 or 2. I think we really want them to be as close to normal aging as possible. And I think my concern is a lot of what Clyde has said, that you see patients that, when they hit their 40s and 50s, cognitively they feel slower, they're having more bowel bladder symptoms, more mood symptoms, and so and I think it's more than what you would expect just for age, and you see it over and over again, and you feel like you've missed a little bit the opportunity.
Well, if you're really going to get that result, you need to make sure they're not overweight, they're regularly exercising, they're not smoking, they're getting good sleep, they're really following a wellness program, they're getting their hypertension optimally treated. They have to look at the whole body. They have to take care of the whole body if they're really going to age well.